Hi everyone, welcome to our second community of interest meeting for head and neck or pathology. I apologize for my voice. I just overnight developed pretty bad laryngitis. But hopefully you can hear me okay. And today we're so glad to have um, Dr. Ilan Weinreb as an invited speaker. And before we let Ilan talk, we're going to have a few housekeeping issues. Today we're gonna have three case presenters, and if anybody have a last minute decision to share a case, you're really more than welcome to do that. And again, let's see where and recording for your case is optional. We want to emphasize that. So we'll save some time towards the end if you decide you don't want your case to be recorded, so we can have more casual discussion together. And also, please keep yourself muted while others are talking. Tap in the chat or raise your hands for questions, and we're gonna see you that way. So in June we have a conflict time. So we're gonna skip our June meeting, and our next meeting will be in September, the last Friday of September, from 1 to 3. Jenny for the event will send a link for registration and a reminder for you to log in. And lastly, we're so glad to have a co-moderator today, Dr. Bayardo, Perez-Ordonez. And thankfully, also because my voice, I'll do, Bayardo is a very experienced and senior respected pathologist over here. So I'm really glad to have him here to bring up more discussion. And I'll ask Bayardo to introduce Ilan because they know each other very well. Bayardo.
Thank you, Lingxin. It is really a privilege and a pleasure to introduce Ilan Weinreb. Yes, I have known Ilan for, I can't remember actually, long time. Dr. Weinreb is actually the current division head of anatomy pathology here at University Health Network. He's also an associate professor in the Department of Laboratory Medicine and Pathobiology at the University of Toronto. Ilan is an expert head and neck pathologist and has accumulated a wealth of experience in tumors of the head and neck in all areas of head and neck, to be honest with you, because he also has his interest in soft tissue sarcoma. So, in fact, he's the first author of what at the time was one of the first case reported of the amelanoma-like Ewing sarcoma in the head and neck. Ilan is also an expert and has a tremendous interest in the chromosomal translocation of all kinds of salivary gland tumors. Actually, I think he's also one of the co-authors in the original descriptions of secretory carcinoma. Probably the first author in the intraductal carcinoma of salivary gland. And so we really have, we're lucky to have him here. He's part of the WHO classification of head and neck salivary gland tumors, and he also is a co-author of the fifth series fascicle of AFE fascicle of salivary gland tumors and tumor-like neoplasm. So I think I have a great deal of respect for Ilan, and actually I'm really lucky that I had him as a colleague for this many years. So Ilan, it's all yours now.
Okay, well, thank you both. I'm going to share my screen and I'm going to take my video away so that I don't do what many people say one does, which is stare at yourself, and which is a little creepy. And also, I don't want to distract anyone else. So I'm going to take myself away and I'm going to share my screen. So thanks again to both of you for not only inviting me, but of course organizing this forum as well, which is a lot of fun and a great place to share cases, and maybe you can get opinions on real-time cases. I'm going to give a talk, a short one that I've given before. It originally had an audience response system, so I had to furiously take out all the quiz cases since we don't actually have the technology in this forum to do that. So I made up this acronym called INHEADS, a tumor acronym for those in the nosebleed section, to remember the entities that you should think about when you see a tumor in the sinonasal tract that has squamous differentiation in particular. So, a lot of people like to talk about this region and talk about small round blue cell tumors. I'm not really going to do that. I'm going to talk mainly about one of the pitfalls, which is squamous differentiation. I often divide talks into, neuroendocrine as a pitfall, squamous as a pitfall, and keratin expression as a pitfall in the sinonasal tract. And I'm going to concentrate on squamous. Okay, so let's see if I can advance again. Now it's giving me a weird beeping sound. There we go. Okay, so INHEADS for me stands for inverted papilloma, nut carcinoma, HPV-associated carcinoma, EBV-associated carcinoma. A is for adamantinoma like Ewing sarcoma, which Bayardo alluded to. D is for DEC-AFF2 sinonasal carcinoma. And S is just to remember that sometimes it's just a conventional squame, and also, if you like, to remember salivary gland tumors that can have squamous differentiation. Although by and large, those are not that common in the sinonasal tract, but they are worth thinking about because, of course, tumors can stain like squames and be of salivary origin. Of course, the only one here that is benign is inverted papilloma or benign aggressive, but since it has the ability to become squamous cell carcinoma, it actually fits quite nicely in this acronym as well. The reason I'm not going to talk about conventional squamous cell carcinoma too much is because I think you all know what it looks like, and usually seen in smokers even when it's in the nose. And by and large, there isn't much of a differential. We don't work up conventional squames that often. The rest of these have a tendency towards non-keratinizing morphology. And so whenever you see a strange tumor with non-keratinizing morphology and squamous differentiation, this is the acronym I'd like you to think about. Again, it's not, there we go, it's advancing now. Okay, so the first is the eye, and this is a nice example of a sinonasal biopsy that we all see quite frequently. In this case, it's actually, I'm purposefully giving you a small biopsy where there is a differential diagnosis. It's not the most obvious, and location in this case is very important. So when you look on the left, you see a somewhat exophytic and endophytic squamous lesion. You can tell even from this power that it's quite bland and squamous, and it's not particularly non-keratinizing, in fact. This case, if it were in the nasal septum, it's small enough that all of this endophytic growth might be fooling you. It might actually be all tangential sectioning. And this may represent a simple squamous papilloma, or we often call them exophytic papillomas, that are uniquely located and solitary in the nasal septum. Whereas if I told you this was a lateral nasal wall lesion or a sinus lesion, you should immediately think, okay, well, maybe I don't have enough tissue, but this endophytic growth is pointing towards an inverted pattern of growth that we might see in inverted papilloma. It's not malignant. You can see also on the right, there were a couple other fragments that aren't that much more helpful, but one of them in particular, I want to allude to, it looks like it has a bit of a brush border-like effect and maybe some mucinous cells. And you also see some gland-like differentiation, which is probably just invaginated respiratory-like glands. And all this might make you think of Schneiderian papillomas like inverted papilloma, but I want you to remember this stromal core for some of the differential diagnosis later. So in a case like this, I went to molecular because I didn't feel very confident that I could be sure, particularly because it was sent as just nasal polyp and didn't tell me the location. And so I did the molecular in this case, and it did in fact show an EGFR exon 20 insertion, which is characteristic of the molecular underpinnings of inverted papilloma. So even with a small biopsy, when there isn't enough morphology, you can sometimes use molecular to still make the diagnosis of inverted papilloma. I will caution you, though, that EGFR mutations in general can be seen in lots of different things. And if it's an EGFR non-exon 20 insertion, it might actually mean nothing. And so we have to be a little bit cautious and make sure that the molecular fits our morphology. The next case I want to show you is another sort of exophytic papillary tumor. And this one, I think you will see, and especially when I show you a higher power, that it actually has at least carcinoma in situ in it. In addition to being very papillary and a lot more bulky than the last one, you can see that there is endophytic growth as well. There are gland-like spaces. There is the same sort of respiratory brush border kind of look with mucinous cells. And again, this might make you think of Schneiderian papilloma, but in this case, it would be a malignant one. And one possibility is that it is a non-keratinizing squame arising in a Schneiderian papilloma. And that's why I'm saying it's at least carcinoma in situ, because then it would be occupying a previous existing lesion with a interface with stroma that is not breached. Whereas if there's no precursor lesion here, we would tend to say that this bulky exophytic and endophytic tumor with this kind of anaplasia that I'm going to show you has to be a carcinoma. So it really depends on whether you have the pre-existing lesion or not as to whether you say it's in situ or whether it's invasive. So just like the last case, I thought, well, maybe molecular will help. Here is the higher power showing you that it's very obviously malignant. That's the easy part. And it showed an NRAS mutation in this case, not an EGFR mutation. So one of the things that we thought about, because NRAS can be seen in one of the cousins of inverted papilloma, which is the oncocytic papilloma, also known as the cylindrical cell papilloma, is we said that this is a papillary squamous lesion with at least carcinoma in situ, and it may have arisen in a pre-existing Schneiderian papilloma, such as an oncocytic papilloma. Now, I'm going to come back to this later, and this is a case that actually highlighted how we should approach these lesions from the beginning. And I'll get into that in a moment. Okay, so squamous cell carcinoma, I'm not going to spend too much time. You know, the vast majority of these don't mimic small round blue cell tumors. They're usually not non-keratinizing or basaloid, but when they are, or even undifferentiated with focal squamous differentiation, that's when we get into this problematic area where we might need ancillary testing. Otherwise, if you see a conventional squame, you're usually safe to say that it's conventional squame and move on. Obviously, these will stain with P63 and a number of keratins, including high molecular weight. Some of them may have a viral association, even if they are conventional appearing. So it's always reasonable to do a P16 in every squamous lesion in the nasal cavity and nasopharynx. It's reasonable to do EBV if you have it, EBR that is, if it's a nasopharyngeal lesion. Most of the time, although I always say do HPV and EBV, most of the time when it's sinonasal, not nasopharyngeal, you don't need to do the EBV. But it's easier to remember that always exclude viral first. The prognosis obviously is better if it is viral than if it's a conventional squame. And if it's a conventional squame, it's going to be better than some of the squamous containing mimics in the sinonasal tract. So this is not an academic difference, even if there is no tailored treatment for each entity I'm going to discuss. And you know some of the variants of squame, including the conventional up here in the left upper hand quarter, the acantholytic, the non-keratinizing and basaloid, which are kind of the same thing, although, you know, the traditional basaloid has the palisading you're seeing here, the comedo-like necrosis and sometimes abrupt squamous differentiation, whereas the non-keratinizing squames look a little bit more you know, heterogeneous in terms of how non-keratinizing each area is, with a little bit Some areas a little bit more pink, some a little bit more blue, and often with lymphoid tissue in the background. You know about EBER, which this is the only thing I'm going to say about EBER, is that it's mostly going to be in the nasopharyngeal location. It can look like anything. It can be non-keratinizing, like in the oropharynx. It can be undifferentiated, so to speak, like we used to call it, which is the classical type. It can have areas of conventional squame as well. It can even have palisading in basaloid areas and even almost mimic a BCC, but those kinds of patterns are actually quite rare. Now, back to the case before, we did forget something, and that's why I sort of segued into the viral component of the talk briefly. We forgot to do something before molecular, which is we did no immunohistochemistry. And so I alluded to the fact that ideally we would do HPV and EBV testing. In this case, actually, it turned out to be P16 positive on the resection of the case. And so we did HPV-ish and it was positive as well. So that RAS mutation actually meant probably nothing. I mean, maybe it was a secondary driver. Maybe it will matter for the patient in terms of the aggressiveness, but it certainly wasn't a diagnostic marker. And we overthought it by saying that it could be a oncocytic papilloma precursor because we forgot what is my new cardinal rule and what we advised the CCO when they were creating, or when we helped them create the sinonasal panel, is that it should always be done only after HPV and EBV have been excluded for this very reason. Not just because it's wasteful, but we may misinterpret molecular that is not diagnostic in the wrong setting by not ruling out HPV and EBV first. So this, in fact, was an HPV-driven tumor, and it goes back to what I said earlier, that because there's no precursor, and we don't think that HPV tumors have precursors, that means it was never carcinoma in situ, at least. It was always a fully malignant, non-keratinizing squamous cell carcinoma with metastatic potential. It just looked like it wasn't invasive. It just looked like it had a pre-existing Schneiderian papilloma because of that combination of exophytic and endophytic growth without any real destructive stromal invasion. So that is definitely a pitfall that we can avoid even without thinking about that pitfall if we just remember to do viral exclusion first. So now I'm going to segue to a different HPV-related tumor that occurs in the sinonasal tract, and that is the HPV-related multiphenotypic sinonasal carcinoma. This is a tumor that, I often call this a recent description, but it's not that recent anymore. It occurs mostly in women and caused by different HPV viruses than the usual type. That is, they are mostly HPV 33, 35, and some other unusual ones have been described. If you get HPV 16 or 18, it's probably not this entity, although I wouldn't say that 100% because there's always exceptions to every rule. There isn't great clinical outcome data, and that is to say, we cannot say that it is definitely going to behave better than a usual squame just because it's HPV related. And that is because the data on sinonasal HPV is just not robust enough in terms of numbers and follow-up. But we can definitely surmise that it will be better than a high-grade adenoid cystic carcinoma, which is what it usually imitates. So this is not academic. How do we know that it's not a type of squamous containing adenoid cystic carcinoma? Well, one thing is we tended to say for a long time that adenoid cystic carcinoma never has squamous differentiation. I don't think that's true anymore because based on some recent studies we've published. But more importantly, adenoid cystic carcinoma won't have squamous dysplasia, which I'm going to show you in a moment. So the combination of HPV and squamous dysplasia are not really compatible with adenoid cystic carcinoma. There have been some reports in the literature of adenoid cystic carcinoma and HPV, but they're probably misdiagnoses. And all of these tumors have been uniformly negative for the MIB and MIB-L1 NFIB fusions seen in adenoid cystic carcinoma. We also know that it's not a conventional squame because not only is the HPV different, but the typical basaloid or non-keratinizing squame of the oropharynx is generally not positive for myoepithelial markers. Even if it does have some cribriform architecture, it will not be a myoepithelial containing tumor. They occur mostly in men, although plenty of women as well, whereas this tumor occurs exclusively or nearly exclusively in women. And as I said before, the HPVs are a different subtype. And in an expanded series in 2017, and we've seen more since, they show any type of myoepithelial differentiation. This can include malignant cartilage, just like a carcinoma X pleomorphic adenoma. So I'm going to show a case provided to me by Justin Bishop, who described this entity, because although we've seen cases, this one is the most adenoid cystic-like example that I have seen. And so this one you can see looks a bit like a high-grade adenoid cystic with nesting and a high degree of atypia. You don't usually see this kind of anaplasia in an adenoid cystic carcinoma, but I suppose you can in the high-grade variants. Here you see the cribiform architecture. None of that would be out of keeping with a basaloid squame of the usual type, but this would. This is showing you that there truly is a biphasic quality to this tumor. So you see luminal marker CAM 5.2 staining actual ducts and P63 staining in an abluminal fashion, sparing those ducts, which is this a quintessential sign of a biphasic tumor, which almost always, except for this entity, suggests that it's salivary in origin. Here's an actin stain, which is diffusely positive. Again, you should not see that in a typical squame of any type, even a sarcomatoid squame, when it gets some myoid differentiation, is usually not this dramatic. And then, of course, surface dysplasia, as I said before, was one of the reasons we knew that this isn't really compatible with an adenoid cystic carcinoma. So fundamentally, this is a squamous lesion. Here you can see the P16 diffusely positive, and the HPV-ish, in this case with a blue color, is positive as well. Now, this is an important point about HPV in general. We can only trust P16 as a surrogate marker for HPV in the oropharynx and in the level 2 and 3 region of the neck in an unknown primary situation. And even then, I would be cautious in the neck because of cutaneous squames that can be P16 positive and HPV negative. And so we have to be very careful not to just use P16 in the sinonasal tract. And in fact, there was a recent WhatsApp group tweet by Jim Lewis, who sits on the CAP committee, saying that the CAP is finally going to recommend HPV testing in squames in the sinonasal tract, which of course we've all been doing for a long time, but they're still recommending that, unlike in other sites, that we continue to prove it's HPV with some sort of RNA test. In this case, this is an example of E6 and E7 mRNA in situ hybridization. We use the same thing at UHN. I believe Sinai does the same. Ours is RNA scope, but there's lots of different products that can be used. Ideally, it should not be a DNA test, and we have abandoned by and large PCR, even if it were RNA, just because of the possibility of contamination. Okay, so getting back to small biopsies, I'm now going to present a case that was sent in as a squamous cell carcinoma, which is the theme, of course, of our talk. This is a 35-year-old male with a facial mass or a premaxillary mass in the soft tissue. The biopsy was called squamous cell carcinoma and therefore thought to be of skin origin. And you'll see in a moment why that's a little unusual, because it doesn't look like a conventional squame. Because of that morphology, of course, we looked at the CT, and it showed actually that there was a large maxillary sinus tumor and that it extended submucosally into the subcutaneous tissues and actually was just a large T4 tumor rather than a skin tumor. And because the patient is so young, SNUC becomes unlikely, which is one of the considerations as well for an ugly looking tumor with small round blue cells. Now, this case you can see here, again, it's a small biopsy. You can see, I think that this was the normal surface skin or mucosa. And then here is that very blue tumor that doesn't look like a typical squame of the skin, which are almost always conventional appearing. You can see here on higher power that there were indeed squamous pearls. And so that's one of the reasons why they called this a squamous cell carcinoma. And they did do immuno, which they shared with us, including CAM 5.2 and P63, which again would be very reasonable for a squamous cell carcinoma, with the one caveat being that the patient is so young. And young 35-year-olds don't usually get squamous cell carcinomas. When they do, interestingly, especially when it's in the tongue region, they're usually conventional, not non-keratinizing, like this tumor. And when they get non-keratinizing tumors, they are usually viral, but it would be very unusual that they would be only 35 years old to be HPV positive. I think, we've seen that on occasion, but by and large, the vast majority of HPV starts kind of in the late 40s and then goes up into the 70s. And EBV can be this young. So we've seen lots of EBV tumors in patients in their 30s, although again, mostly older than that, but much more common than in HPV. So of course, we do both viral surrogates or the in situ hybridization in the case of EBV, and they're both negative. If you do get a P16 negative, that is sufficient without HPV-ish or any other RNA-based test. It's only when it's positive that we want to prove that it truly is HPV. So this patient is young with a non-viral tumor. It's non-keratinizing rather than conventional looking. So there's something not quite right about this being a squame, and it's certainly not quite right to be a SNUC. And this is not the same case, but it's just an example of what would happen if we use the NUT antibody in this case. We did have NUT, but we don't have it in file, so I couldn't show you a picture of that specific case. So this is a picture I got from Chris French a number of years ago of NUT immunohistochemistry, and in this case it's positive, and this is indeed a NUT carcinoma, which very well explains the patient being 35 years old. So NUT carcinoma, which we no longer call NUT midline carcinoma, originally was a carcinoma thought to affect only children and in the midline. Ed Stilo was one of the first people to do a decent sized series in the head and neck and showed that 5 of 28 of their SNUC cases in their files were actually NUT carcinomas. Most of these patients were older adults, which is interesting because most NUT carcinomas we tend to think of as being young. The age range was wide, and in these cases, they typically had some form of squamous differentiation, whether it was a couple cases with abrupt squamous differentiation, or most of the cases being at least P63 positive. And of course, we don't consider P63 by itself proof of squamous differentiation, but it certainly should make you think about NUT carcinoma. NUT carcinomas, as I alluded to before, are much worse than conventional squames, even of non-viral conventional squames. And the progression in 2 years is and death in a short period of time is very high. So this, again, is much worse than viral and much worse than conventional squames. So it warrants ruling out. We actually don't have the NUT antibody anymore. We actually have problems with it in terms of it not being consistently staining the control, so we abandoned it. And now we rely on molecular alone. This is a nice case from Ed Stilo's series. One of the reasons I like it is it shows a couple things. The first is that the squamous differentiation is very abrupt, right? You could draw a very nice line around the squamous differentiation, and there doesn't seem to be an in-between phase. And the squamous differentiation is actually completely bland to the point where you wouldn't call this tumor malignant based on the squamous differentiation that you're seeing. You'd call it malignant based on the round cells in the background. And that's the other important point. Most squamous cell carcinomas, whether they be on the blander side or on the uglier side, they don't tend to be monotonous. There's quite a bit of nuclear pleomorphism. In this case, you can see that all the cells really do look alike. It's one of the reasons I like this particular picture, because it looks like a round cell or spindle/epithelioid tumor where all the cells look very similar. A very common finding in fusion-associated tumors in general, including Ewing's and others, and also very common to see an ugly tumor that doesn't have a lot of mitoses. That's, again, another sort of sign of a fusion-positive tumor. Having said that, a lot of NUT carcinomas are uglier than this and are plenty mitotically active. So the most common fusion is BRAD4 NUT. There's also a BRAD3 NUT. I don't know why people don't call this nut bread. I've always thought that nut and bread together is an obvious kind of, I don't know what the right word for it is, but calling it the nut bread carcinoma would have, I think, been fine. Also, now people tend to call it NUT M1, which is the true designation of the gene. This can be tested by FISH. I don't know of anyone who does that in Ontario, but most of us now who do sort of larger panels have NUT M1 on our panels. And in fact, the CCO panel that we help to sort of put together does have NUT on it as well. If you do have the NUT antibody working, it's a very good one, particularly in terms of its specificity. Sensitivity is not bad either, but again, in our case, it had 0% specificity when it's, or 0% sensitivity when it stopped staining the control tumor. This is sort of the other end of the spectrum of NUT carcinoma, when it's extremely sort of high grade and discohesive even, and starts to look like a diffuse large B-cell lymphoma. So not all cases have squamous differentiation. Not all of them have P63 staining. Keep in mind also, when you have P63 staining of a tumor like this, it actually could still be lymphoma, because P63 is a known pitfall in lymphoma. And so we're really trying to abandon P63 in favor of P40, but I've noticed that most people just do them both now, instead of having switched from P63 to P40. And then this is the other end of the spectrum, and why this tumor specifically belongs in the talk about non-keratinizing squam. So recently we've seen about 5 cases, we being a number of different people in different places. I know that Ilan Han, and Christina McMillan, and Lingxin, of course, saw one at Mount Sinai a number of years ago. We saw one in consultation. I think this is the case we saw from Quebec. And we know of others with some of our colleagues in the States and in Europe. So we've got a half a dozen cases of these now, of NUT carcinomas that look like a papillary, sort of blander but still non-keratinizing tumor that looks, the squamous is the easy part in this version of NUT carcinoma, where you look at it and you're like, oh, this is a non-keratinizing squamous cell carcinoma. Maybe even, could this be a benign tumor if you have a small enough piece of it? Could it be a papilloma, Schneiderian, or other? And you can see, once again, it has similar sort of stromal cores that I showed you in that one fragment of the inverted papilloma at the beginning of this talk. This is the same tumor, again, highlighting that basaloid morphology with the peripheral palisading. It's a little bit blander than the NUT carcinoma tumors before. And what we saw in this tumor, and interestingly was reported in one of the tumors from Memorial at this last USGAP, is this much weaker NUT staining. And this might not be a consistent thing. It might just be a couple cases, one of ours and one of theirs. But it might be that NUT doesn't work as well in this particular variant. This happened to have an NSD3 NUT fusion, but we've also seen this pattern with a typical BRAD4 NUT, and NSD3 NUT has been seen in other typical NUT carcinomas. So I don't think that link will be that strong, although most of the cases have had the variant NSD3 NUT so far. We're hoping that we can show after a period of time that these half dozen cases and hopefully more will actually have better outcome as well, because of the blander morphology. Maybe it will point to a less lethal tumor, most NUT carcinomas being almost universally lethal. So having shown you that morphology, I now want to show you another case that had a similar sort of appearance, a non-keratinizing looking, clearly squamous lesion with these edematous stromal cores, again, with this sort of exophytic, somewhat bossylated look, rather than like strictly papillary. And you can see here, one of the characteristics of this particular tumor is these squamous eddies that look not so much like squamous pearls, but almost more like an eddy, like a whirl of squamous differentiation. You can see, once again, it's quite bland. There are inflammatory cells that include neutrophils percolating through. And again, you can see the vascular and or edematous stroma in the background. Here's another case. You can see again that edematous stromal core. You can see some of these fragments might make you think of the slightly endophytic architecture of an inverted papilloma, and maybe you would think, well, since it's non-keratinizing, it must be dysplasia arising in an inverted papilloma. Just, it's not that very, not a high grade enough to call it that. And again, we would do viral markers here and they would be negative, and then we would potentially do molecular. This is something I'm calling the Lakitu sign, reminding you about these edematous cores. I don't know if you're Super Mario fans, but this is Lakitu. He's the little guy who sits on the cloud and throws things at Mario, who's trying to run and dodge them. And this is courtesy, again, of Sinai. Ilan, after his fellowship with us, developed this antibody at Sinai for AFF2, which works quite well, as you can see here. And thank you to him for providing this. This was a known DEC-AFF2 carcinoma, and it has variably been called DEC-AFF2 sinonasal carcinoma, or DEC-AFF2 sinonasal squamous cell carcinoma, or non-keratinizing squamous cell carcinoma. Fundamentally, they are of squamous differentiation, so I prefer to list them as a variant of squamous cell carcinoma.
Ilan,
Yes.
there is a question in the chat.
Okay.
Amishita Kak and in Hamilton. Is there a reason why not immuno was done in the previous case?
Okay. Yeah, fair question. So I'm going to say that I don't know, because it was done by the submitting pathologist. So as I said, we can't do NUT anymore because it failed to be reliable in our lab. I think it was sent by the contributor from Quebec as query DEC-AFF2 because of the similar architecture and appearance, and they had obviously the sort of the right kind of differential in mind and had done NUT, but they were not confident based on the results, and presumably didn't have access to the molecular. So they were hoping to sort of rule in DEC-AFF2 if appropriate, and if not, what else could it be? And it turned out that it did in fact have a NUT fusion. So this case is, and thanks for pointing that out, Bayardo, because I can't see the chat while I'm in presenter mode. This is a lacrimal duct mass. You can see it's actually quite extensive on higher power, or sorry, on microscopy. You can see that there is a little bit of eyelid here and conjunctiva here, and then of course this large mass, this sinonasal mucosa here as well. And so this is a large mass. You can tell that it has a papillary architecture here, and then it looks like it's involving like a space here as well. And this is actually very reminiscent of the carcinoma in situ that I showed you earlier, that I said had RAS mutation and it turned out to be HPV. So you can see that the morphology is quite overlapping between a lot of these tumors. This tumor is more like a round cell tumor with abrupt squamous differentiation. This was a middle ear DEC-AFF2 case. You can see that this abrupt squamous differentiation is, again, kind of not in and of itself malignant looking. And so that's actually very reminiscent of what I showed you in the nut carcinoma. And again, kind of typical of what happens in fusion-associated tumors. This is another case we saw very shortly after the initial description of DEC-AFF2 carcinoma, of a DEC-AFF2 adenosquamous carcinoma. And it stands to reason that you can get glandular differentiation in this variant of squame, just like you can get in other variants of squame. Notice again that similar bossylated sort of papillary-like architecture with the stromal cores that you can see in a number of the tumors in this differential diagnosis. And then the last thing in my in-heads that I'm going to discuss is the A, not the E, for adamantinoma like Ewing's, but I'll start with Ewing's sarcoma alone. We know that it affects about 4%, sorry, 4% of Ewing's are actually sinonasal tract or head and neck. It's actually quite a common location. Overall, it's uncommon compared to other sinonasal tumors, but it's not that uncommon in general. It's probably the only common mucosal site for Ewing's sarcoma. They occur at a wide age range. They can metastasize to lungs and bone. They do not they do not present with nodal metastases, unlike alveolar rhabdomyosarcoma. So the differential of a round cell tumor is often these two tumors, Ewing's sarcoma and alveolar rhabdo, because all other tumors are so rare in this site. And they do typically show EWSR1, FLY1 fusions and variants similar to other parts of the body. So I won't dwell on this, but one of the things that we've seen many times in this location is that Ewing's sarcoma can have more of a nested pattern in the sinonasal tract. One theory that I had was because of the fibrovascular stroma inherent to this region, it might be less permeable to these tumor cells, and maybe they sort of work their way around it and cause nesting, but that's just sort of a hand-waving kind of guess. Typical Ewing sarcoma morphology can be seen with this small round cell and bland morphology, clear cytoplasm due to glycogen, which of course can also be seen in alveolar rhabdo, and CD99 crisp and membranous staining, which of course is by itself not diagnostic, but it's helpful when it's not diffuse and membranous in terms of not worrying about Ewing's. And the reason I say that is that in the entire differential I've given you so far with squamous differentiation, the only thing that doesn't qualify as a carcinoma, although that's debated as well, is the adamantinoma like Ewing's sarcoma. So if you want to call something non-keratinizing squame, see comment and say we're going to do immunomolecular, you can do that only if you're happy that it's not Ewing's, because Ewing's is the one thing that isn't a carcinoma and might have been falsely called carcinoma. Everything else can be called non-keratinizing squame, and then you can say, oh, and we found NUT in it, which is not surprising, or DEC-AFF2, or EBV, or HPV, or inverted papilloma in the background. So if you get a negative CD99 or a wishy-washy one, then you can do that. If you get one that's positive, which we had recently in a case where we were thinking it was a squame, then you should hold back and either not sign it out or call it a malignant neoplasm with squamous differentiation. Just don't use the word carcinoma. Here is just a reminder that Ewing's, just like rhabdo and like many things, can have neuroendocrine and epithelial differentiation, usually patchy, weak, or focal, not usually diffuse. If you get wall-to-wall keratin positivity, especially if it's more than one keratin, you can pretty much bet that it's not going to be a sarcoma, but never say never. And now I'd like to talk about the A in heads, which is adamantinoma like Ewing sarcoma, which, as Bayardo alluded to, we saw the first case here in Toronto in the neck that didn't involve bone or pre-bone soft tissue. So they were all previously extremities in the tibial area in particular. This is a nice example of what once we might have called an atypical Ewing's, with much bigger nuclei, prominent nucleoli, and a bit more mitotic activity than usual. And of course, this one in particular has abrupt squamous differentiation, just like you saw in DEC-AFF2, just like you saw in NUT. The squamous differentiation in and of itself does not look malignant, and the cells around it abruptly change to very ugly looking cells. When you see that, think fusions. CD99 was positive, but in this case, so were squamous markers, including P63 and CK5. And this had an EWSR1 rearrangement by FISH and an EWSR1 Fly1 fusion by, at that time, PCR. And now, of course, we would use NGS. So with that, thank you for listening. This, again, is a reminder of the pitfall of squamous differentiation in tumors that aren't conventional squame in the head and in the sinonasal tract region. And the take-home message is always start with viral exclusion. And after that, if it's conventional looking squame, you're done. If it's not conventional looking squame, you pretty much need molecular one way or the other, because you need to either exclude, well, you don't need to exclude the X-inverted papilloma. You can exclude that, but you do need to exclude the NUT, the Ewing's, and the DEC-AFF2, all of which can be on the CCO panel that a number of us, including UHN and Sinai, can offer. And if you don't have EBV, again, don't worry about it. Just do the P16. If it's negative, then you can send it on for the CCO funded testing. Okay, with that, I'm happy to take any questions.
Thank you, Ilan. That was a really great talk, very practical. I do have a question about the HPV-related multiphenotypic sinonasal carcinoma. So sometimes we don't, well, like you said, we don't usually see the classic adenoid-cystic carcinoma-like morphology, but we do have the surface dysplasia, and it's apparent it's coming from the respiratory mucosa. So in that case, if we don't have any other more glandular differentiation, do you still prefer the term a multiphenotypic sinonasal carcinoma, or do you just call it HPV-associated carcinoma? Period.
Yes. So we've seen a lot of these cases that are in between, as you said, without the obvious S100 positive, actin positive, by layered tumors. And then the question is, how much basaloid architecture versus cribriform, how much of it is enough? In the past, we had a linear array DNA PCR panel that had the HPV 33, 35 on it. And if we were kind of leaning in that direction and got the right HPV, we would call it that. Now we're all, as I said, first of all, the linear array PCR is not available anymore. The Sinai PCR in micro that we share in the micro lab doesn't have HPV specificity outside of 16 and 18. So it's 16, 18, and then non-16, 18. So we can't really use that either. I know that Ilan, when he was with us and probably still at Sinai, he likes to send it to public health because they will sort of on a research basis rather than clinical give you HPV subtyping. So you can do that. But the truth is, I think in the end, and the WHO reflects this by not really including it as a unique tumor compared to other HPV squames, I think it is fine to call it just an HPV non-keratinizing squame. And you can say this may be a typical one, or it may be the so-called multiphenotypic sinonasal carcinoma, if it's not classic. Maybe Bayardo has opinions of this as well, because I know that he's had some cases that were called multiphenotypic. Sometimes it'll be a patchy result. So because part of the tumor is actin positive, we kind of lean in that direction, particularly if it's a female patient. But again, as you said, without knowing the subtype of HPV, and particularly in a male patient, if it just looks like a strange non-keratinizing squame, I prefer to call it that, because I think the clinicians know what that means more than they do the multiphenotypic anyways. So that's kind of a hand-waving answer for admitting that the sort of classical adenoid cystic-like tumor are pretty rare. And you'll remember that the original description was only 4 cases found on a TMA of adenoid cystic, right? So that classical adenoid cystic-like tumor is pretty rare.
Thank you. Okay, so everybody, you can still feel free to type in the chat if you have questions for Ilan. But for time purpose, we're gonna move on to our case presentation. The first presenter is Dr. Ramandeep Kaul from St. James University Hospital, Lake, UK. So, Dr. Kaul, you can start sharing your PowerPoint. And if you have trouble, I can do it from my end. Thank you.
Hello, everyone. So I'll be starting with case 1, disclaimer. This is a case of 44 years old female who presented with left sinonasal mass. This was an endoscopic resection, which was done in February 2024. Patient had a past history of debulking of the lesion from same location in 2021, which was reported as non-keratinizing squamous cell carcinoma arising from inverted papilloma. She was given concurrent chemoradiotherapy, which she completed in December 2021, and now they suspected recurrence this time. CT showed a mass at the site of left nasolacrimal duct with extensive post-surgical and radiotherapy-related changes within the nasopharynx. MRI showed a bilobular nodular soft tissue in the superiormost aspect of the nasal passage, involving the base of frontal sinus. There were no enlarged or morphologically abnormal lymph nodes within the neck, and no focal mass was seen within the upper aerodigestive tract. So microscopically, this is how the tumor looked. Part of the tumor looked very papillary, and elsewhere it was more of confluent papillae forming sheet-like architecture. Again, showing the well-formed papillae with delicate fibrovascular cores and confluent papillae forming sheet-like architecture. And the tumor comprises monomorphic, almost all the cells looked similar, with abundant neutrophilic infiltrate. And these cells had monomorphic nuclei with small nucleoli without any much nuclear pleomorphism, and they were only scattered mitosis. And part of the tumor looked very oncocytic without much nuclear atypia. On immunohistochemistry, tumor showed patchy positivity with CK7. P40 and P63 were diffusely positive. CK20, synaptophysin, chromogranin A, and S100 were negative. P16 and HPV both were negative. INI1 and BRG1 were retained. Eberish was done, which was negative. And this was reported as sinonasal carcinoma with oncocytic morphology, and tumor was sent for NGS, which detected DECF2 fusion. It was negative for EGFR, KRAS, and NRAS mutations. So final diagnosis of DECF2 fusion-associated papillary squamous cell carcinoma was given. It's a novel entity. Despite the low-grade histology, these tumors tend to behave aggressively, involving adjacent vital structures, frequently recur, and are inclined to develop lymph node and distant metastasis. This justifies more aggressive clinical management, and the literature has shown these tumors to be potentially sensitive to immunotherapy. This case, patient was discussed in MDT and considered for immunotherapy. PDL1 was done, which was negative. So according to NHS protocols, as per NICE guidelines, without if PDL1 comes negative, they don't go for immunotherapy. So cure was attempt to cure was decided as further surgery, as she has had radiotherapy in the past. So in recently 2nd of April, salvage left orbital exenteration with skull base resection and maxillectomy was performed. Thank you. Any questions?
And actually, your case reminded me of a case I had about 2 years ago. It looks almost identical. And as Ilan said, and our Ilan has developed AFF2 immuno that we have been, have available at Sinai. We sometimes get requests from outside to do the immunos, and we are still in the process of validating the sensitivity and specificity. But it so far has been working pretty well.
Okay, we don't have F2 immune, so we only rely on NGS.
I think NGS is also good, depending on again the cost, reimbursement, and also the turnaround time.
Thank you. Thank you for giving me this opportunity to present on this
Ilan is
platform.
here. Thank you for
Yeah,
bringing
it's nice.
it.
It's I guess it's a little more specific to do the NGS because you get the partner. Anecdotally, I think there's an SCAP presentation where there was a non-DEC fused partner, which still was IHC positive. So I think they're only, anecdotal cases so far.
I I have a comment, and I would like to know Lingxin and anyone's opinion. We in referral centers often, or with some regularity, do see recurrent squamous cell carcinomas or inverted that originated, or there is the clinical history of a previous inverted papilloma. Do you have, Ilan, Lingxin, anyone, do you have a basic philosophy about these tumors? Because my impression is that probably DEC is not a new entity. It just has been recognized recently, and some of these tumors were burying some those so-called carcinoma X inverted papilloma. So, do you have any approach or philosophy in diagnosis of these tumors? Because many of these, we didn't know what the role of HPV either in these tumors, right? The literature at the time, the old literature is full of controversy about HPV being a prognostic factor in inverted papilloma for malignant transformation.
So when it's interesting. So when I first saw our case at Sinai with Christina, the entity diffusion has not been identified at that time. And while we were working up that case, we run into a case report from 2015, and it was from it's actually from Washington University, where I did my residency. Dr. Jim Lewis was the first author, and they published that case under the term of low-grade papillary Schneiderian carcinoma. And this term has been also used sporadically in the reports, but I think it's very likely they represent the same entity as DAC-KEV2. Just based on the morphology, I think the commonness with inverted papilloma is that it all come from the Schneiderian epithelium. And I agree with you. This is not perhaps is recognized, diagnosed entity, albeit probably lumped in the wastebasket of carcinoma arising from either inverted or atrophic Schneiderian papilloma in the past. So I don't know. Like so far, we still don't know what is the difference of these patients, how they behave, and what specific treatment would they benefit from if we label it as additional DAC-KEV2. So I guess we need to probably do more collaborative research and have a more systemic clinical and pathology correlation studies to really understand how does these cases different from the conventional squamous cell carcinoma arising from inverted papilloma. That is my take.
It sort of relates to one of the cases that Ilan showed today, the KRAS with HPV, and the thought, like, can HPV itself make something look papillary, or does it need a mutation to actually be a true inverted papilloma? Because that is in the literature that you have HPV-driven inverted papillomas. So I think there's also something there. But without seeing a lot of cases representative of the natural history, I think it'd be hard to, come down on how, how these go and what goes one way and what goes the other way.
All right. Well, people are thinking about our questions or comments. I'm gonna share my case here. Second case of the day. Again, pardon me for my voice. I'll try to get it through. So the patient is an 80-year-old gentleman who initially presented with headache and unilateral proptosis. On imaging, the CT had showed a soft tissue ossification of frontal sinuses with breach of the sinus wall. Let me see what I can show. Laser. So sure what I can see my is breaching the medial wall of the front, the lateral wall of the frontal sinus, as well as there are also intracranial extension. And on radiology, the radiologist differential based on the location was either neuroblastoma or also in consideration is non-neoplastic aggressive infection. Anyway, we got the biopsy. So we got an incisional biopsy of the patient's frontal sinus and ethmoid sinus cells. And there are just fragments of respiratory type lining, as well as some infiltrating normal proliferation of neoplasm cells in a somewhat nested pattern. You see there are various sized nests and sheaths, solid growth of what appears to be pretty typical cells with high NC ratio. On higher power, this nest seems to be all surrounded or lined by either thin basal cells, or these could be all representing lymphovascular invasion by tumor cells. There is some occasional clearing of the cytoplasm, but the majority of the cells have pale eosinophilic cytoplasm, pretty fascicular chromatin, small nucleoli, and there's frequent apoptotic bodies. Mitosis is not very frequent. In other areas, you see communal type of necrosis. And again, the tumor is very infiltrative, and it seems to be inciting a desmoplastic reaction in the stroma. Again, it's hard to tell initially whether these spindle cells are part of the neoplasm or it's just a stroma proliferation in reaction. On immunohistochemistry, the epithelial cells all stain up as positive for pancetokeratin, and not so much in the background spindle cells. But by morphology, I favor them to be all desmoplastic reaction. Again, here you see the tumor cells diffusely positive for pancetokeratin. There's some weak, very patchy, non-specific P63 staining, and also focal synaptophysin staining. The remaining of the markers, including P40, P16, S100, SOX10, CD34, chromogranin, keratin, and GFAP are all negative. So there's this another acronym. So Ilan gave us a good acronym in HAS for squamous lesions in the sinonasal tract. And this acronym was brought up as actually by Dr. Jim Lewis. He was one of my favorite attending during residency. And this acronym is for small round cell tumors in the sinonasal tract, nose alarm. So our immuno profile basically has excluded majority of these entities, including NUT, carcinoma, olfactory neuroblastoma, olfactory carcinoma, squamous cell carcinoma, small cell carcinoma. SNOC remains in the differential. Then Ewing sarcoma, adenocystic carcinoma, lymphoma, alveolar rhabdomyosarcoma, sarcoma, and melanoma have been basically excluded. So SNOC, or the sinonasal undifferentiated carcinoma, is not a uniform entity. It has been used as a basket bin for anything that doesn't fall into any of the differentiated or known lineage. In this case, for the next step is to add I91, which was attained, but a BRG1, which is SMARCA4, was clearly lost, and all the tumor cells retained in the background normal glands and the stroma cells. So the final diagnosis of this is a SMARCA4 BRG1 deficient sinonasal carcinoma. We went ahead and did a molecular. Interestingly, apart and finding a frame sheet that is basically non-functional, inactivating SMARCA4 mutation, we also found a concurrent missense mutation in CTNB1. And after we saw the result, we added beta-catenin immunohistochemistry, and we see there is diffused nuclear and cytoplasmic staining in the tumor cells. So indeed, it is correlated with a apparent beta-catenin or CTNB1 function in this case. we did not see any gene fusions by NGS. So the first case of SMARCA4 deficient nasal carcinoma was reported in 2017 by Dr. Nagami and Weinreb. And since then, there has been over 20 cases reported in the English literature. The largest case cohort includes 10 cases, and it's by estimate that this entity constitutes about 4% of fully differentiated or undifferentiated sinonasal tumors. There's a male predominance, and half of the reported patients actually passed away from disease within several months. So very aggressive tumor. They often presented with high stage disease, like in our patient. There's frequent orbital cranial invasion. These patients or the tumor doesn't really respond to multimodal therapy. They usually have undifferentiated epithelioid or basal cell morphology, sometimes overlapping with neuroendocrine carcinoma. And unlike the SMARCB1 or INA1 deficient carcinomas, we rarely see a rhabdoid morphology in these tumors. And tumor cells are usually
So I have
usually
two
diffusely
DMO
positive
Mastercards,
for
and I can add it to any
keratin,
one of these.
and there will be focal neuroendocrine markers, but squamous cell markers as well as not are usually negative. So one of the recent case series of 2 cases presented in China actually had a good demonstration of the morphology spectrum. So the one on the left has a lot of resemblance to ours, arguably more typical cytomorphology, and there's clear cytoplasms in some of the areas. And the one example on the right side actually looks somewhat like neuroendocrine carcinoma or small cell carcinoma. And these authors also performed NGS and found concurrent activating CDNB1 mutation and SMARCA4 deficiency in these tumors. And the SMARCA4 deficient tumor is not the only one with these 2 mutations simultaneously. The other entities included teratocarcinosarcomas and the newly defined olfactory carcinoma. Both of them have a neuroplastic as well as epithelioid differentiation. So really the interesting question is whether they could be genetically related entities. And although despite there being on a spectrum of morphology. So as a summary, it's important to recognize when you're considering not carcinoma or SNUC that is presenting as a high stage aggressive tumor, consider the possibility of a SMARCA4 deficiency tumor. I know a lot of institutions have INI1, but may not have BRG1. So consideration if your INI1 is retained, then maybe find a resource to BRG1 as well. What we didn't mention is, of course, WHO defined also within the SNUC with basket, there's IDH2 mutant tumors, which all could have overlapping morphology. And that was my first case. Any questions? Before I move on to the second one.
Thanks. That's a great case. I know we talked about it at the time, but I think it's interesting to raise, how are we diagnosing these? Top line, are we going to diagnose them by the specific genetic alteration, sort of like outlined in the WHO? Or is it more, mechanistically or biologically accurate to diagnose them as something with a SMARCA4 deficiency? You could see technically you could see any case with SMARCA4 loss. And would that cause people to recategorize them as SMARCA4 deficient sinonasal carcinoma? Or are we keeping the old diagnosis and just adding about the SMARCA4 loss? I think at the end of the day, you know, if something's going to drive prognosis and treatment, as long as it's in the top line, it doesn't really matter on the top line it is. And this is pretty semantic, but something, you know, I've been thinking about with as we see more of these cases. You know, we have SMARCA4 now on the molecular panel, so I find myself doing the stain retroactively when I find a mutation in things that I haven't really considered, like a thyroid tumor, for example.
Yeah, the SMARCA4 deficient neoplasms have been, I think, initially well characterized in the lung. The Sloan Kettering group reported a group of SMARCA4 deficient pulmonary carcinomas that also behave very aggressively, and it is a common theme wherever the primary tumor is. If it has SMARCA4 deficiency, they sort of have a similar morphology. You know, like also the INI1 deficient ones, and they seems all have the common theme of being very aggressive, poor prognosis.
I have a comment, although it's in the list of the SMARCA4 related neoplasm, you have olfactory neuroblastoma there. I think we have to remember that olfactory neuroblastoma, the clinical pathologic features are well described, and often the prognosis depends also on stage and grade of the tumor. So at least in that entity, we still should continue diagnosis as such, using the conventional immunohistochemistry combination of pathologic features and immunohistochemistry. So I think there's still room for specific morphologic diagnosis. Yeah.
Yeah, I agree. I think that's more of an honest way to do it in general. If it's a poorly differentiated tumor, I would be more inclined to call it SMARCA4 deficient carcinoma if there's nothing else, you know, putting it in a category. But if I'd otherwise have it in a category, I'd probably have it in that category and maybe top line it with SMARCA4 loss.
So, what is your take of the olfactory carcinoma? I have actually a case recently, but I was debating whether to call it undifferentiated or olfactory neuroblastoma or olfactory carcinoma. It is still a relatively new entity. Not sure if anyone has been kind of adopted a terminology in their practice.
Steve Smith has his hand raised.
Oh, yeah, for a different question, though. So sorry, I'm not responding with Xing. I don't have an opinion on this.
Bayardo, any comments?
So, sorry, can you repeat the question?
So
checking the chat. Sorry.
Yeah, that's right. So recently, the terminology olfactory carcinoma has been proposed for tumors with both neuroplastic and epithelial differentiation. So basically, when you see a like olfactory neuroblastoma, but not exactly looking like olfactory neuroblastoma and staining for keratin, it's proposed that it's being called olfactory carcinoma. Have you used this term before?
I haven't used that term, but I know, especially in the high grades and those with rosette formation, because some of those rosette are truly epithelial rosette. So I don't think we still have the last word in those cases. I have never seen, well, I have never reported one. Remember, this is just, what, about 3 years old, 4 years old paper. So I really don't have a position, but I do know from previous work that olfactory neuroblastomas, especially when they have rosette formation, they can be positive for keratin.
Yeah, well, to that point, and then I'll ask my question, but I was just going to say, I don't know that I would adopt the generic term olfactory carcinoma myself, unless it starts getting, I just worry that no one's going to know what it means. And this comes from a lumper, not a splitter. I'm a big fan of trying to put things together and not split hairs as best as we can, but I worry if I use something too generic. It almost sounds like a 1950s pathologist type of thing where we didn't know what anything was, but it was carcinoma and occurred in the olfactory tract, so we would call it that kind of a thing. I was just going to ask for anyone who uses INI1 or SMARCA for immunohistochemistry, do we have enough faith in those markers as immunohistochemical stains alone to where you would run them, and if it comes back deficient, you would trust it and report it out and not do the molecular? Or are we generally always sending this for confirmation with molecular? I'm wondering if we've gotten to the point where we're willing to trust those yet.
I may just start. I think personally, because on the sarcoma side, we use INI1 routinely, and it has been quite a reliable marker. Like not long ago, we don't even have SMART A4, SMART B1 on molecular panel. So I feel pretty comfortable when I see a INI1 loss or BRG loss in a tumor, as long as the internal control works properly and is kind of diffusely lost in the tumor, I'll report it. And even in this case, I don't feel like there's a must to do molecular confirmation.
Yeah, I agree. I think it's been pretty good. I sort of use it the other way if I have a SMARCA4 or SMARCB1 mutation as like a functional test. If it's not well categorized, for example, if it's not like a truncating type of mutation, then I'll use it. I'll use the IHC to confirm the finding. But yeah, I guess technically you could have like larger deletions that may not be found on a panel that would be detected by the IHC.
Yeah, my other comment is I have used it a few times. But you gotta remember the context where all these antibodies are used, right? You wouldn't use it in your garden variety of squamous cell carcinoma or other entities where an initial diagnosis can be reached by a whole panel of immunohistochemistry based on what you see under the microscope, right? Usually we end up with this antibody, at least in the tumors in the sinonasal tract, is because we have gone through that diagnostic algorithm, and the morphology actually is telling us that this is might be one of these cases, right? Yeah, so that will be, once I've done that, I think I would trust the result, right?
I think we have time, but for another case. But if anyone have to leave early, please feel free to do so. And after this case presentation, we'll ask Jenny to stop recording so that we'll have a few minutes of free discussion. And if anyone wants to share a case, even if you don't have a slides, please feel free to do so after we stop recording. And here we go. Let me do this next case. This patient is a 60-year-old man, non-smoker, who presented with a large maxillary sinus mass. And initially, clinically, the clinician thought it to be a second nasal inverted papilloma. On diagnostic imaging, they described a large case centered within the right maxillary alveolus, extending into the right maxillary sinus, with osseous destruction of the underlying alveolar ridge and hard palate. A biopsy was done outside of sinus and showed a moderately differentiated squamous cell carcinoma, but at the same time, P16 was positive in a block-like pattern. So the patient was referred to Sinai and underwent a total maxillectomy and neck dissection. At this low scanning power, you can see this tumor is breaking through the hard palate. It's hard to see, say, from this section where it is actually coming from. It's filling up the maxillary sinus, but it seems that it's also, part of it is in the oral cavity. And higher power, you can see it actually has a conventional keratinizing squamous cell carcinoma morphology, where there's predominant squamous cell differentiation, and the tumor cells showed quite prominent polymorphisms, frequent apoptosis, and very brisk mitotic activities. There's comedo type of necrosis. And if we look at areas, this section is taken from the hard palate oral cavity section. You can see there seems to be a transition from normal squamous epithelium to atypical or dysplastic epithelium to carcinoma. So it seems that this tumor did arise from a squamous mucosa. And in contrast, I'm just putting the side to side our current case and a textbook HPV-associated or pharyngeal non-keratinizing squamous cell carcinoma. You notice that a typical HPV-associated carcinoma has very syncytial growth of the tumor cells in distinct cell borders, relatively monotonous cytology, and although you could see maturation focally, you usually do not see so much of keratinization as in our case. So there seems to be discrepancy between the morphology and the P16 result. I repeated P16, and I have to agree with outside pathologists that there seems to be a diffuse block-like positivity within tumor cells. Next thing I did is I added P53, and it is also aberrant. It has a null pattern. We have an in-house high-risk HPV mRNA cocktail in situ hybridization, and that is negative. So at this point, I know it's likely a conventional or keratinizing squamous instead of HPV-related entities that's coming from the oral cavity and growing into the sinonasal tract, rather than a HPV-related entity. And how to explain the P16 staining? Well, the concurrent P53 aberrant pattern IHC make me think there's probably an underlying mutation involving either CKNB1 or the RB complex. I don't usually do molecular studies on these cases, but for this one I did. It did, identify a stop codon, a nonsense mutation in P53 involving the DNA binding domain that explains the null pattern P53. There is a missense mutation in CDKN2A. We didn't see any mutations in RB. Our panel right now doesn't give us a lot of information on copy number alterations. So I found this old paper back in 1999, but a very, good study. So the authors look at the functional results of P16 or CDKN2A gene, and how does the different variants mutation correlate with protein structure information. So in one of their figures, in figure 1, they did immunoprecipitations using wild type P16, and you can see because functionally P16 binds to CDK4 and CDK6 in control of the G1 phase of the cell cycle, that the wild type P16 binds to these two markers and will pull them down in an immunoprecipitation. However, the D84Y, which is the same mutation as our own case, did not show any detectable binding. And from a the protein perspective, the D84, which encodes aspartic acid, is a very strong holding point, binding point for CDK4 and CDK6. And that mutation actually will make it the P16 protein non-functional. And that's very interesting. But in terms of why it actually what it does to the downstream RBE complex and how it affected the transcriptome level of P16 stain, this paper didn't give a really clear explanation because it's not a focus. I couldn't find a good paper in the pathology literature explaining correlating different P16 mutations to our P16 immunohistochemistry profile. But what I suspected is dysfunctional P16 protein actually activated downstream feedback mechanism that will promote more P16 being produced, therefore the overexpression in our case. So, I would like to discuss a little bit about how we diagnose HPV-related carcinoma outside of the oropharynx. As Ilan has mentioned, like the majority of the HPV positive carcinomas are found in the oropharynx, and vice versa, the majority of oropharyngeal squamous cell carcinoma are HPV related. And the next common location to find HPV positive carcinomas is actually indeed sinonasal tract, but only accounts for about 20 to 25% of squamous cell carcinomas in this location. In oral cavity and other head and neck size, the incidence is even lower. Although P16 has been proven to be a very robust surrogate marker in oropharynx, the specificity outside of oropharynx has not been established. As a matter of fact, we know is probably not very reliable. And so if we look at what is a good strategy when we are dealing with discrepancy between morphology and a P16 staining pattern within and outside oropharynx. So I really like this paper, and the strategy in this paper is so the authors essentially performed morphology analysis, P16 immunohistochemistry, and high-risk HPV PCR in 378 oropharyngeal carcinomas, and they found about 5% of the case being discrepant in terms of P16 stain and mRNA level. And they found that these cases, when they analyzed the survival of these cases, really the RNA seems to have be more reliable in predicting whether these cases are more favorable diagnosis and response to radiation therapy or not. And they found that the morphology is actually the strongest or most useful feature for identifying patients at risk for discordance. And the authors recommended that we reserve, from a practical perspective, in the oropharynx, we reserve the MRI testing only when the P16 status and tumor morphologies disagree. And this has been the same strategy that I've been using. So, but outside of oropharynx, I don't trust P16 as much, and especially when the morphology strongly suggests a conventional squamous cell carcinoma, then I think it's a good idea to have a HPV-ish for prognosis and for information to our clinicians. So, as a just take-home message, P16IHC is not a validated surrogate marker for HPV carcinomas outside of oropharynx. And when you have discordance, you may consider doing confirmatory HPV mRNA testing, either PCR or ISH, to resolve the discrepancy. And I would also, with that, I was also curious to see what are everybody's strategies for diagnosing HPV positive carcinomas, and when do you use ISH, and when do you use P16 alone?
So there's a debate. Sorry, I'm just going to jump in. I've gone rogue. I was just going to say there's a bit of a debate right now as to the utility of P16 outside of the oropharynx. And CAP, I believe, is going to be releasing soon some recommendations, I think, regarding that particular subject, in addition to updating their HPV and P16 recommendations that they've had for 4, 5, 6 years now. But I was just going to say, generally speaking, if I get a block positive in the nasal cavity, I go down the same route that you did, and I would have gone down this exact same train. I would have found it extremely unusual, but I found block positivity in of P16 in other tumors that were not HPV driven, and I've always just assumed, well, there's a lot of reasons why P16 can be upregulated and overexpressed in things.
Yeah, I mean, for a long time, we have known that there are some squamous cell carcinomas in the nasal cavity that are HPV associated. So I think the strategy that we have been using here, and it's not unique to us, right, is we do a screening for P16 in sinonasal if they resemble non-keratinizing squamous cell carcinomas. And I do the same sometimes in a very rare laryngeal, especially supraglottal larynx, that they have that non-squamous morphology. If I get a let's assume, even with the non-keratinizing morphology in those sites, I do confirm that with in situ hybridization. Because remember, you can have some classic basaloid carcinoma outside of the oropharynx, right? The problem with the term basaloid is that it's a very liberal use of the term. It's not used as it was initially described. And that initial paper, this is probably a 35-year-old paper, had basaloid squamous carcinomas in several sites, not just the oropharynx, but there was a paper from WashU, Samir Al-Mufti, I think is the senior author, where he confirmed that the basaloid morphology is highly correlated with HPV in the oropharynx. In other sites, it's not. Now, we do know, especially in, and I'm going to apologize here, because when I do get conventional nasopharyngeal carcinomas, and this I'm talking non-keratinizing types and undifferentiated. When they are EBV negative, my next step is actually to do P16 and HPV, because now we know that there are some nasopharyngeal carcinoma that are HPV related. But I never use P16 only as indication of HPV outside of the oropharynx.
Thanks, Bayardo. I think we're on the same page regarding this. So I'm gonna ask Jenny to stop recording.